Welcome to Lecture 2 of E&M. Just got done talking about office or other outpatient guidelines. Let's go ahead and move to medical decision making. What I want everybody to do now is go to your textbook. With the textbook, we have exercise 11-1. Make sure you complete those 6 questions. They'll just kind of review everything that I just talked about. And then let's move on to table 11.1. 11.2, 11-3. So we have the basic elements of medical decision making. One nice thing, as I stated, you will not have to decide the level. The level this semester will always be given to you. So let's go ahead and look at table 11-2. These are times for each of those levels. So if we look at 11-3, those are for established. 11-2 was for new patient. On the page before that, I just want to talk about the time. This gives you great examples. So what they're saying here, that what is all included in that time component? What can I all include in that 99215 40 to 54 minutes? So if the provider reviews documentations prior to the appointment. So let's say the provider looks through the prior documentation, takes the provider 5 minutes. Okay, so that's 5 minutes of time. They obtain review separately obtained history. So they go into the patient and say, okay, I don't know if they asked this of you, but tell me about your family history of a certain diagnosis, right? That is included in time. Performing the appropriate exam, evaluation. So let's go back to, let's say the patient came in really bad abdominal pain. They're possibly getting a history, is there any stomach issues in your family, any cancer, anything like that. And then they asked, or then they do the exam. They take bowel sounds. They feel the abdomen, just your routine exam for that type of diagnosis or symptom. Then there's counseling to education to the patient that you can count that in as time. Ordering any medication, test procedures. So if they have to leave the room and then get on the phone and say, hey, I want to order this test at this facility, that can be all accounted for as time. So with that, also communicating with other healthcare professionals. So let's say that this internal medicine doctor calls a gastroenterologist and says, I want to schedule a referral to you to see this patient. Not sure quite what's going on. It's something deeper than internal medicine. That can be also put into the time component. Documentation of any, clinical information. So the doctor or the physician is putting all that documentation in. That can be time. And then any results that are given to the patient, family, or caregiver, that is all included in that component. All right, let's move here to hospital observation. When a patient admitted with the same observation status and discharge on the exact same day. All right, so let's go to codes 99234, 99236 in your CPT book. So with these 3 codes here, they can be outpatient or inpatient. So let's say a patient gets admitted to the hospital in the morning and the doctor performs a history and physical. Then that night, the doctor says, we're going to discharge you, goes through all the discharge procedures, lumps it all into one code. All right. You cannot code. There is a code for admission into the hospital all by itself. And then there's a code for discharge from the hospital, all by itself. Those codes are done on one day and the discharge is a different day. If they are admitted and discharged the exact same day, these codes have to be used. If you separate them out, then you are unbundling and you are charging too much. One interesting thing, this is admission, so admit as an inpatient or observation, which is outpatient. These codes can go either way. Let's look at it says Medicare has time constraints on these codes. Let's go ahead and look at 99236. 85 minutes must be met or exceeded. So it doesn't matter if a lot of times if they go over for Medicare, all right, just Medicare. If they go over for any other third party, you can actually add a prolonged service code 99418. So write that in your notes. It's actually in your CPT book in little parentheses. So you can add an extra code. All right, so this just breaks down a little bit more of that. We have hospital inpatient or observation service. Now, this code here does not have the discharge with it. This is we're just getting admitted or we're getting admitted into observation. So these codes here are 99221, 99223. As you can see in your book, that these can be on decision making or time. All right. So with this here, patient starting an observation, then admitted, it doesn't matter. You're going to go still, you're going to add probably the times together on these and then still use one of these codes. Types of physician status. We have attending, this is where the primary admitting physician, or consultant, physician whose opinion or advice is requested by another physician. So consulting. Let's talk about consulting. Consulting physician gives advice about a particular aspect of their care. They do not assume additional responsibility. So this would be an example. A patient was in there for, let's say they're having a appendectomy, something, fairly easy, pretty easy going surgery, no complications. But also now the patient is having heart palpitations, atrial fib. So the surgeon calls in cardiology to do a consult to make sure that, there isn't anything more that maybe they can calm it down, status of this goes away. That cardiologist isn't taking over care, they're just coming in, checking out the heart aspect of this patient's admission. Okay, so we have types of care. We have concurrent care given to a patient by more than one physician. So we have a pulmonologist and a cardiologist. The example I gave before, I said the cardiologist didn't take over, but what if the cardiologist did not take over but needs to be in there, keep checking on that atrial fib? Then that would be concurrent care. So at this point, they can both put in a visit for that day. So with those visits, we have, let's go back to 99231 in your CPT book, 99231 through 99233. These are subsequent hospital, inpatient, or observation. What I want you to write in your book is daily visits, right? So I'm admitted to the hospital, let's say for pneumonia, admitted to the hospital for pneumonia. And the doctor did the initial admission, which would be, let's just say, a 99222. The doctor comes in the next day to visit me to do, a little examination, decide what my next step is. That doctor at that point would code something from 99231 through 99233. Subsequent inpatient or observation care. So keep in mind with that, those are subsequent. All right, we have two different types of hospital inpatient or observation. You have initial, which I just talked about, and the subsequent, which I just talked about. So initial or observation care, go ahead and mark. These again are what we just talked about, 99221 through 99223. They're used only once for each admission. Can't code these more than once. Other physicians who come in, they have to bill a consultation or that subsequent hospital care as I talked about. as appropriate. So 99221 through 99223 can only bill once per admission or per hospital care. This, I always like to tell students, is the history and physical. The physician is doing a history and physical on that patient, and they're admitted to the hospital. Okay, so subsequent hospital or observation care. This is after initial, and you bill these daily. Usually, I would hope that you have a higher level, and then it gets to be a lower level towards the end of that patient's hospital. Hospital or observation discharge services. These are going to be codes 99238, 99239. So with these are not, okay, these cannot be on the same day. So you have discharge, 30 minutes or less would be a 99238. 99239 is more than 30 minutes. So these are the two code, and it can be done for inpatient or outpatient discharge. Final status of the patient, condition, medications, plan to return to the physician, how hospital stay progressed, discharge home, to the nursing facility, where did they go? Unique to discharge codes, only the attending physician can use a discharge code. You don't have a doctor who comes in to consult use a discharge code. So write this by your 99238, 99239. This code is based on time spent, beginning and end. All right, let's talk about consultation codes. These are kind of interesting because right now we have, cardiologists use them, orthopedic surgeons use them, urology, depending what type of specialty they're calling in. So what they are is one physician requests another physician's opinion. Doesn't matter, these can be new or inpatient or outpatient, sorry about that, or new or established. So we have codes 99252 through 99255. So here again, the appropriate history, appropriate exam, and then decision making. If you don't have the decision making and the doctor documents time, we can use that component time. Let's talk about time real quick. Let's say that the doctor puts down that they saw the patient 79 minutes. One thing to remember, you cannot round up. So I would have to code 99254. Just a heads up here, you can never round up. So we can only have one consult by consultant per hospital admission. The consultant provides a report of opinion or advice, and it's documented in the medical record. Third, payer party consultants. Request a confirmation, past medical treatment, current condition, bill using inpatient or outpatient, apply 32 modifier. Remember, this is a mandated service that we're stating this has to happen. This is interesting, and this happened a while ago. 2010, payment for Medicare consults are no longer reimbursed. So if this patient is Medicare and they call in a cardiologist, that cardiologist just has to use a regular hospital subsequent visit. A regular hospital subsequent visit. Or if that cardiologist is doing a consult in the office, it would have to be an office visit. All right. So if the patient is Medicare, you cannot use a consulting code anymore. All right, let's go to the ER codes 99281 through 99285. So these are how your emergency department, doctors, physicians, physician assistants, nurse practitioners get paid. There are codes for new and established patients. Doesn't matter, they don't distinguish one or the other. So that's always something you need to look at when you look at the codes. Doesn't matter if they're new or established, This scenario, they don't. So, qualified as emergency department or ER must be open 24 hours a day and be able to have unscheduled visit. That is emergency department. Has to be provided by emergency department staff. 99281, that is only reported by clinical staff only. So it may not require the presence of a physician or other qualified healthcare professional. This could be somebody, once again, stating, go into the ER and they will take your blood pressure. Critical care and emergency department codes. Your ED services often require additional codes from critical care services, and those are in the next section. Critical care 99291. So with critical care, one thing is provided to patients in life-threatening situations. The type of service will depend on the condition present on arrival in the emergency department. And codes are based on time. Here is a very important thing I want you to all write down. They have to be reported with the appropriate E&M. All right? Total time less than 30 minutes, reported as with the appropriate E&M. So, if they're saying that only 28 minutes was done with critical care, you don't do the critical care. You just put it with the time of the office visit or whatever visit you're doing. So keep in mind with that. Critical care services, we have our 99291, which I said 30 to 75 minutes, 74 minutes, sorry. 99292, each additional. Over 24 months of age, outpatient. Over 71 months of age, inpatient. Total time under 30 minutes is reported with an E&M code. All right. I do recommend that everybody go ahead and read through critical care services in your CPT book. This will just help explain a little bit more than my lecture. It'll give you a little bit more insight. You know, different areas of this, it talks about the total duration. And, you know, it doesn't have to be all at one time. It also will talk about exactly what you have to do to perform critical care. All right, critical care, just because they're in ICU doesn't mean that they're performing critical care. It's one thing to remember. Just because they're their intensive care unit doesn't mean the doctor is performing critical care.